Hey, pediatric team, let's talk brains and senses.
Welcome to the deep dive.
Yeah, welcome. Today we're diving deep into, well, the really complex world of pediatric neurological and sensory disorders. But we want to cut through the noise a bit.
Exactly. We've taken a pretty comprehensive source text on this, and we basically pulled out the key stuff, the essential knowledge, the insights you actually need.
Right, to boost your confidence in understanding these conditions and, importantly, caring for our young patients.
Think of this as your shortcut, maybe.
Yeah, exactly. Our mission here is to give you those key takeaways, those aha moments, and just get you ready to make a real difference, you know?
Okay, so let's start with the basics. The foundation, the brain and how it develops.
Right.
We're talking the nervous system, the fundamentals, the central command, brain and spinal cord.
And then the peripheral network, the nerves reaching out everywhere else.
And the key player, the star, is the neuron, right? The nerve cell.
Imagine them like tiny electrical wires and myelin. That's the insulation.
Helps those signals zip along fast and efficiently. Keeps things moving.
So the brain itself,
Yeah.
main parts.
Well, you got the cerebrum, that big wrinkly outer part that's handling, thought, voluntary actions.
Higher level stuff.
Right. Then underneath, the cerebellum. That's crucial for coordination, balance.
Keeps you upright and moving smoothly.
And the brainstem, down the base. That's managing the absolute critical survival functions, breathing, heart rate, that kind of thing.
Okay, so what's really fascinating for us in PEDS is how predictable this whole development process is supposed to be.
Totally. It follows a known path, certain milestones, especially in those first few years. It just accelerates.
But what happens when that journey gets thrown off course?
Well, that's where the problems start. Could be genetic, metabolic, maybe an infection, trauma. Lots of things can disrupt it.
And that leads to challenges like seizures, sensory processing issues, developmental delays, a whole range.
And this is where reflexes come in. They're like these little early windows into how the nervous system is wired.
Okay, like the deep tendon reflexes, tapping the knee.
Exactly. That's testing at the spinal cord level. Tells you about the communication between the CNS and the peripheral nerves, the muscles.
So if those reflexes are weak or decreased.
Might point to a problem out in the peripheral nerves.
Yeah.
But if they're super brisk, exaggerated.
Then you're thinking more upstream,
Yeah.
central nervous system issue.
Often, yeah. Then you've got the primitive reflexes. These come from the brainstem. They're there right at birth.
Like the baby grabbing your finger.
Palmar grasp, yeah.
Yeah.
Or the Moro-Startle reflex. They're normal, even important early on.
But they should disappear on a schedule, right, as the brain matures.
That's the key. If they stick around too long, past when they should fade, or if they're missing from the start, that's a really significant warning sign.
Suggests the higher brain centers aren't developing properly to kind of inhibit them.
Exactly. They're not taking over with more complex voluntary control like they should.
So spotting these signs, these subtle things during assessment, it's just huge.
Your role as the nurse, your observations, they're absolutely central to catching delays early.
So when you're doing a neuro exam on a kid, it's not just one thing, it's the whole picture.
Right. You look at their mental status, sure, but also how are they behaving, interacting, their
Yeah.
mood, activity level, are they lethargic, super irritable? How are they holding themselves, their positioning?
Level of consciousness, obviously. Is it stable,
Yeah.
changing? Checking cranial nerves, motor function, sensory responses.
Super response equal reactive. Coordination. And those reflexes we just talked about.
Don't forget the musculoskeletal check too, right? Spine, joints, how they walk their gait, muscle strength.
And the history. Just as vital. You need the whole story.
Not just the immediate issue, you need the backstory. Prenatal, birth history, postnatal.
Their overall health path.
Yeah.
Any previous seizures, infections, big illnesses, accidents.
And really dig into those developmental milestones. When did they sit up, walk, talk? Critically, have they lost any skills they used to have?
That's a massive red flag. Aggression.
Definitely. Ask about behavior concerns, family history, maybe migraines, epilepsy, other neuro things. Social factors too, parenting styles, socioeconomic issues, they can play a role.
And during the physical exam, some specific findings are just pow right there. Head circumference, especially in babies.
Gotta measure it accurately, plot it. Watch for microcephaly too small or macrocephaly too big.
And a good point from the source, use the right growth chart for that child's population. That's part of culturally competent care.
Muscle tone is another big one. Hypertonia stiff, increased tone, or hypotonia kind of floppy, decreased tone. Look for any muscle wasting, atrophy.
And here's something interesting. Check the skin. Neurocutaneous disorders often show signs on the skin.
Because the nervous system and skin develop from the same embryonic layer, right?
Exactly. So things like multiple cafe au lait spots, those light brown packed or clustered skin lesions, they can signal underlying conditions like neurofibromatosis.
So measuring those lesions is actually part of your neuroassessment.
It can be. Also, look for dysmorphic features, anything unusual about their appearance, signs of cranial nerve problems like a droopy eyelid, wyetosis, or maybe trouble using their tongue.
Or physical signs you might recognize from specific genetic syndromes like Downs.
And to help screen systematically, we use standardized developmental screening tools.
Yeah.
You might hear names like ASQ, DDST2.
They don't diagnose, but they flag kids who might need a closer look.
Right. They identify kids at risk for delay.
Mhm.
But honestly, sometimes the best screening is just watching a kid play. How do they interact, move, problem solve?
Okay, this brings us to a really critical point. Something like 17% of kids have a developmental or behavioral disability.
Yeah, it's high.
But less than half are actually identified before they start school.
That gap. It's
Oh.
huge. It means lost time for intervention.
Early diagnosis isn't just nice, it's optimal. It's absolutely crucial for the best outcome.
Finding things early lets that whole multidisciplinary team get involved. PT, OT, speech, educators, psych, social work. When the brain is most plastic, most able to change.
Okay, let's shift gears a bit. Talk about some specific structural challenges. Hydrocephalus is a big one.
Yeah, hydrocephalus. Simply put, it's too much cerebrospinal fluid, CSF, building up inside the brain.
CSF is that fluid cushion, right?
Yes.
Circulates around the brain and spinal cord.
Right. And if there's a blockage somewhere or the balance of making it and absorbing it is off, it builds up and that causes pressure.
And how it shows up. It's really different depending on the child's age. Because of the skull bones.
Exactly. In babies, their skull bones haven't fused yet. The fontanelles are open, so the head can actually expand.
So you see that rapid head growth.
Yeah.
Bulging soft spot.
Uh-huh. Lots of vomiting, often forceful projectile. They can be really irritable or lethargic. Maybe that high-pitched, shrill cry.
And as pressure gets worse.
You might see sunsetting eyes, where the eyes seem to gaze downwards. Even episodes of apnea, stopping breathing. Or opisthotonos, that severe arching of the back.
But in older kids, their skull is fused. It's a closed box.
Right, so the pressure builds up inside. Their symptoms are different. Severe headaches, often worse in the morning.
Sometimes relieved by vomiting, right?
Exactly. Vision changes, maybe blurred or double vision. Balance problems, clumsiness. Changes in school performance, personality shifts, even new onset incontinence.
Diagnosis usually starts with your assessment, confirmed with imaging, often an MRI.
And the main treatment is surgery, placing a VP shunt.
Ventriculoperitoneal shunt, basically a tube.
Yeah, a thin tube that drains the extra CSF away from the brain, usually down into the abdomen, the peritoneum, where the body can just absorb it.
So, nursing care. Pre-op, it's getting those baselines, head circumference, fontanelle check if they're young enough, vitals, LOC, and lots of teaching, supporting the family.
Post-op. This is where your sharp assessment is absolutely critical. You're watching for signs of increased pressure, sure, but you are especially watching for shunt failure or infection.
What does shunt failure look like? Or
Yeah.
infection?
Okay, so signs of malfunction or infection can overlap. Sudden, rapid vomiting is a big one. A severe headache that just won't quit. Increased irritability or lethargy, a change from their baseline.
Fever.
Definitely fever for infection. Also look at the incision site, redness, warmth, swelling, drainage. And watch the dressing for CSF leakage, that halo sign.
Ah, yeah. The yellowish ring around a blood spot on the gauze.
That's it. That suggests CSF is leaking. Any of these signs need immediate attention. It's critical.
Positioning after surgery.
Usually flat initially, or maybe slightly elevated on the unoperated side or their back, depending on surgeon preference. Yep. To avoid draining too fast or too slow. You also have to watch for overdrainage.
Symptoms of that?
Can be headache, nausea, dizziness. Happens if the shunt drains CSF too quickly, sometimes called slit ventricle syndrome if it's chronic.
And teaching families before they go home. What do they need to know?
Incision care, definitely. Knowing all those signs of malfunction or infection we just listed, they need to be vigilant. Activity restrictions, usually avoiding contact sports, maybe swimming, until the surgeon clears them. Pain management.
And helping them understand that shunts aren't always permanent, right? Revisions are often needed as the child grows.
Absolutely. That's a really important expectation to set.
Okay, let's move on to another really common challenge. Seizures.
Right. Seizures. Basically sudden, uncontrolled bursts of electrical activity in the brain.
And if they keep happening unprovoked, That's when we call it epilepsy.
We all picture the classic tonic-clonic seizure, the shaking, loss of awareness, but there's so many types.
Yeah, like absent seizures, those brief staring spells where they just zone out for a second. Myoclonic seizures, sudden, quick muscle jerks. Atonic seizures, drop attacks where they suddenly go limp.
And then seizures that start in just one part of the brain, focal seizures. The person might stay aware or their awareness could be impaired. Sometimes they have automatisms like lip smacking or picking at clothes.
And we can't forget febrile seizures, super common in young kids, triggered by a fever, usually benign, but scary for parents.
Definitely. What triggers other seizures? Sleep deprivation is a huge one.
Especially in teenagers.
Oh, yeah. Also stress, illness, flashing lights sometimes, missing doses of their anti-epileptic meds.
Diagnosis. A lot of it relies on the history, doesn't it? What the caregiver actually saw happen.
That eyewitness account is gold. Then an EEG, electroencephalogram, measures brain waves, helps classify the seizure type.
And a practical tip from the source, getting an EEG on a little one, try to schedule it during nap time.
Yes, much easier to get a clean reading, minimizes muscle movement interference, and sleep can sometimes bring out abnormal brain activity. Really helpful.
Treatment usually starts with anti-epileptic medications, chosen based on the seizure type. And for kids prone to febrile seizures, treating fevers quickly is key.
And for prolonged seizures at home, parents can be trained to give rescue medications.
Like rectal diazepam or intranasal midazolam.
Exactly. Usually given if a seizure with loss of awareness lasts longer than, say, 2 minutes or whatever the doctor specifies.
So when do they need to call 911?
Okay, critical points here. Call 911 if the seizure lasts longer than 5 minutes, or if they gave the rescue medicine and the seizure doesn't stop after that. Also, if the child has trouble breathing afterwards, gets injured, or has repeated seizures back-to-back.
Any lengthy seizure is an emergency, needs IV meds, maybe respiratory support.
Right. Which brings us to what you do, the critical nursing actions during an active seizure. Safety first.
Okay, number 1, turn the child onto their side.
Keeps the airway clear, lets saliva or vomit drain out, prevents aspiration.
Number 2, never, ever put anything in their mouth. No fingers, no bite blocks.
Big risk of injury to them and you. They won't swallow their tongue.
Okay. 3rd, do not restrain their movements.
You can guide them gently away from danger, but don't hold them down. You could cause a fracture or other injury.
4th, loosen any tight clothing, especially around the neck.
Ensure breathing isn't restricted.
5th, protect them from injury. Move furniture. Put something soft under their head if they're on the floor. Pad side rails if they're in bed.
And 6th, time the seizure. Note when it started and when it ended. That duration is really important information.
After the seizure, the post-ictal phase. What then?
They're often sleepy, maybe confused, might have a headache. Just stay with them, reassure them, let them rest comfortably. Reorient them gently as they wake up.
In the hospital, for a high-risk kid, you'd want oxygen and suction ready at the bedside.
Absolutely. And try to have IV access established if you can anticipate seizures.
Yeah.
Though you wouldn't usually try to start one during the seizure unless absolutely necessary. Pad bed rails are a good idea too.
And promoting safety outside the hospital.
Yeah, important teaching points for families. Helmets for bikes, scooters, contact sports. Water safety is huge. Supervised bathing. Always. Door unlocked, stay within earshot. No swimming without direct, close supervision.
Sleeping arrangements.
Avoid upper bunk beds if possible. Lower bed height can reduce injury risk from a fall during a nighttime seizure.
And that seizure action plan you mentioned.
Yes, such a practical tool. Every family, school nurse, caregiver should have one. It spells out exactly what the child's seizures look like, what meds to give, when to give rescue meds, and crucially, when to call 911. Takes the guesswork out in a stressful moment.
Okay, we obviously can't cover every single condition in depth, but let's touch on a few other important areas: infections, meningitis, and encephalitis.
Absolute emergencies. Need rapid recognition and treatment.
These are infections of the meninges, the brain's coverings, or the brain tissue itself. Key signs.
Sudden high fevers classics, although infants might actually be hypothermic, have a low temp. Severe headache. Stiff neck, you might check for Koenig's or Brzezinski's signs. Those maneuvers that cause pain with meningitis.
Photosensitivity, sensitivity to light.
Vomiting, yes. And altered mental status is really key, especially for encephalitis confusion, profound irritability, lethargy. In babies, look for extreme irritability, being difficult to console, maybe sluggishness, and that bulging fontanelle.
And a rash, especially that purpuric, bruise-like rash.
That's a huge red flag. Can indicate Neisseria meningititis, bacterial meningitis that can make someone crash incredibly fast. Medical emergency.
So the critical takeaway, any child with a fever and lethargy or significant irritability, you have to suspect meningitis until it's proven otherwise.
Absolutely. Diagnosis relies heavily on a lumbar puncture, an LP, to analyze the CSF.
Positioning for that, usually side-lying, knees tucked up.
Right, helps open the spaces between the vertebrae. Post-procedure, they usually lie flat for a bit, monitor the site for bleeding or CSF leak.
Treatment is rapid antibiotics, often broad spectrum at first until you know the exact bug. Supportive care and infection control precautions are vital.
And important to remember, even with prompt treatment, these infections can unfortunately leave long-term problems, hearing loss, learning disabilities, seizures.
Okay, so let's bring this all back home, back to you, the pediatric team listening. We've covered a huge range, from brain development basics to really critical conditions like hydrocephalus and seizures and meningitis.
Yeah, the goal wasn't to turn you into neurologists overnight. It was really to highlight the patterns, the key signs to watch for, and the practical things you can do.
It really hammers home the power of your assessment skills, right?
Hmm.
Looking beyond the chief complaint, catching those subtle clues in the history, the physical exam, head size, skin, muscle tone, reflexes.
And always thinking about where that child is developmentally. Are they meeting milestones? Have they lost skills?
And remember those specific nursing actions we talked about. What to do during a seizure, how to monitor that VP shunt, knowing the signs of infection. Those aren't just textbook points, they are immediate actions you take.
And the teaching. Empowering families with knowledge about shunt care, their seizure action plan, why treating fevers matters if their child has febrile seizures, avoiding triggers. Even simple things like mosquito bite prevention in areas with Zika. That's huge.
Ultimately, this knowledge empowers you. Your vigilance, your sharp observation, your ability to put the pieces together, it matters so much.
You're often the first one to spot a subtle sign, the one providing that immediate life-saving care during an emergency, the one patiently teaching a worried family.
You really do make a profound difference for these kids and their families. They're some of our most vulnerable patients.
So let's leave you with a final thought to chew on, based on our deep dive today.
How does understanding that predictable path of neurological development and knowing all the ways it can be disrupted sharpen your observational skills? How does it make you look just a little bit closer, listen a little more intently for those early, subtle clues in every single pediatric interaction you have?
Something to think about.
Stay alert, stay ready. See you in the next one.